Hello, future nurses and science students. We are the lymph nodes, and we are the elite border security checkpoints and military bunkers of your body's defense system. We are small, bean shaped structures measuring anywhere from a few millimeters to 2 centimeters in size. You don't just have one or two of us, you have an entire network of about 600 lymph nodes strategically placed all along the path of your lymphatic vessels. We group ourselves in massive defensive clusters at major junctions where your limbs meet your trunk, specifically in your neck, cervical, armpits, axillary, and groin inguinal. In your clinical practice, you will constantly feel for us during physical exams. Our main mission in life is simple. We act as inline fluid filters, trapping dirt and cellular debris while serving as the primary staging ground where Luke the lymphocyte and Max the macrophage assemble to inspect the fluid and launch targeted strikes against invading pathogens. Anatomy, the structural blueprint. To understand how we filter fluid so efficiently without a mechanical pump, you have to look at our internal architectural blueprint. We are engineered like a high-security prison with a one-way traffic system. 1. The fibrous capsule and trabeculae. We are wrapped in a tough outer protective shell made of dense connective tissue called the capsule. Extensions of this capsule, called trabeculae, reach deep into our internal space like concrete dividing walls, splitting our interior into distinct organized rooms. 2. The traffic jam, afferent versus efferent vessels. This is a classic anatomy and physiology exam favorite. We are built to intentionally create a fluid bottleneck to give your immune cells time to inspect the afferent lymphatic vessels. We have multiple incoming pipes that pierce through our outer capsule, dumping raw, unfiltered lymph fluid into our interior from all directions. The sinuses. The fluid slowly sloshes through narrow maze-like pathways called the subcapsular and medullary sinuses. Efferent lymphatic vessels. Once the fluid is completely filtered, it exits through only one or two outgoing pipes located at our indented center doorway, the hilum. The mechanical design. Because there are many doors to get in, but only one door to get out, the fluid is forced to slow down to a crawl inside us. This gives our resident immune cells plenty of time to screen every single drop of fluid for enemies. 3. The internal zones, cortex and medulla. Our interior rooms are packed with specialized defense forces. The outer cortex. This is the B-cell territory. It is packed with round structures called lymphatic nodules containing germinal centers. When an infection hits, Bonnie the B cell multiplies rapidly here, causing these centers to swell as they transition into antibody factories. The deep paracortex, this is the T cell territory. Tommy the T cell patrols this zone, inspecting incoming antigens presented by scouts. The inner medulla, the central core. It contains medullary cords packed with active antibody-secreting plasma cells, and Max the macrophages, who line the exit channels to catch any escaping debris. The major functions of the lymph node. For your proctored assessments, you can summarize our daily workload into two primary steps: mechanical filtration and immune response activation. 1. High efficiency mechanical filtration. As lymph fluid crawls through our internal sinuses, the resident macrophages act as heavy-duty janitors. They use phagocytosis to swallow up and digest dead cellular debris, worn-out tissue fragments, soot or dust particles brought from the lungs, and stray bacteria, ensuring the fluid is scrubbed clean. 2. Smart biological surveillance and activation. We are the premier meeting place for innate and adaptive immunity. When a macrophage or dendritic cell swallows a virus in a local tissue, like a cut on a finger, it travels up the lymphatic pipe and enters our doors. It presents that viral antigen trophy to the helper T cells in our paracortex. Once the match is confirmed, the T and B cells rapidly clone themselves, causing the node to physically enlarge. The B cells pump antibodies into the exiting lymph, which eventually drains into the bloodstream to neutralize the virus body-wide. Common lymph node pathologies. When we catch a severe infection, or when cancer cells hijack our drainage pipes to spread through the body, our physical characteristics change completely. 1. Lymphadenopathy, swollen nodes. This is a general clinical term meaning an abnormal enlargement of the lymph nodes. How a node feels during a physical palpation assessment provides critical diagnostic clues. Infectious lymphadenitis, when an area is actively fighting a local pathogen, like a bacterial throat infection, the local lymph nodes will swell up rapidly due to the massive influx of white blood cells and fluid. Malignant infiltration, cancer. Metastasizing cancer cells frequently break away from a primary tumor, slip into the open-ended lymphatic capillaries, and get trapped inside our filters as they travel downstream. Instead of being destroyed, the cancer cells can anchor inside us and multiply, forming a secondary tumor mass. Image comparing an inflammatory reactive lymph node versus a tumor-infiltrated malignant lymph node. Critical nursing assessments and clinical applications, palpation characteristics, the infection versus cancer rule. This is a top-tier nursing blueprint concept that you will use during every head-to-toe assessment. When you use your finger pads to palpate a patient's swollen lymph nodes, you must document their texture, mobility, and tenderness. The infection presentation, nodes that are swollen, soft, highly tender/painful, and freely movable indicate a normal, healthy immune response to a localized infection like strep throat or an ear infection. The localized pain is caused by rapid swelling stretching our fibrous capsule. The malignancy presentation, nodes that are painless, rock hard, and fixed/immobile, meaning they are stuck tightly to the underlying tissue and cannot be nudged back and forth, are a major red flag for cancer. Painless, hard, fixed nodes require an immediate medical referral and a diagnostic biopsy. Sentinel lymph node biopsy. In oncology nursing, especially for breast cancer or melanoma, providers will perform a sentinel node biopsy. They inject a radioactive dye near the tumor and track which lymph node the fluid drains into first, the sentinel node. The surgical rationale: if the surgeon cuts out that first sentinel node and it is completely free of cancer cells, it means the cancer has likely not escaped into the lymphatic highway yet, saving the patient from having to undergo a radical clearance of their entire axillary or inguinal node cluster. Post-node clearance lymphedema. Risks: if a patient does require an extensive surgical removal of their lymph node clusters, such as an axillary node clearance for breast cancer, you must remember that their localized fluid drainage infrastructure is permanently destroyed. Nursing action: you must place a limb alert restriction on the affected extremity. Never take a blood pressure reading, start an IV line, or perform a blood draw on that arm. The constriction of a blood pressure cuff can completely collapse the remaining microlymphatic vessels, triggering irreversible, painful lymphedema, severe fluid backup, and swelling. Always protect that limb. Follow us on YouTube, Felix K's. Explore for more. Otherwise, like, share, and follow us if you enjoyed the class. Thank you for your support.